Hello, everybody. And first, I'd like to wish a happy World Family Doctor Day to everybody. You're very welcome to today's webinar called Key Concepts for Mental Resilience. My name is Diarmuid. I'm the Communications Officer at WONCA, so I work in the Secretariat at WONCA. And I'm joined by two leaders of the WONCA Working Party in Mental Health. First, can I present Professor Christos Lionis from Greece. He's Professor Emeritus at the University of Crete, a family doctor, and Professor of General Practice and Primary Care. And he's the chair of the WONCA Working Party on Mental Health. I'm also joined by Professor Christopher Dowrick, originally from Ireland, now based in the UK. And he's the previous chair of the WONCA Working Party of Mental Health and a general practitioner and emeritus professor in University of Liverpool. And so basically the idea behind today's webinar stemmed from the beginning of this World Family Doctor Day campaign back in January or February. I had a meeting with these guys and we discussed what should be the key messages, what's the important things that we wanted to say as WONCA, as the World Organization of Family Doctors, as people who've thought deeply, as these gentlemen have, about mental health and primary care, and what was the most important messages that we wanted to share with our community. And the conversations that we had were just very engaging and very interesting, that we decided as one of our webinars that we had planned, we would basically try to recreate some of those conversations that we had in the early stage about what family doctors can do to promote mental health, what frameworks, what concepts to think about. And so that's basically the point of the webinar today. A little bit of housekeeping. We encourage a little bit of questions and chat. This is basically going to be kind of a free-flowing conversation. So if you have a contribution, we welcome you to write in the chat. We'll also, if we have time, have a Q&A session at the end where we can invite people to speak themselves. Sorry, technical issue. And we have a maximum of 100 people that can join the meeting, but if we reach any more than that, we can start streaming onto Facebook Live as well. And I'll set that up. But first, I'd like to go to Professor Christos and asked him about a concept he was teaching me about, which is a concept of eudaemonia. Christos, what's eudaemonia?
Thank you very much, Diarmuid. It's a pleasure for me, and many thanks, of course, to you and to my friend and colleague Chris. But initially, before just responding, it's very important in expressing my thanks and pleasure and privilege for all the people that attending this webinar. I'm seen in face of important friends and colleagues from previous executive board of WONCA Working Party on Mental Health, but also I'm now seeing many Greek colleagues, leaders, and friends who are working together. Truly very privileged. Thank you for giving me such opportunity in discussing about two important concepts for Greek philosophers, and that we needed a little bit in discussing and utilizing in our life, especially eudaemonia and mental ataraxia. Eudaemonia just reflecting the concept of well-being means for many scholars is a human flourishing, stems from the Greek words elph, which actually means good, and demon, which translated the understanding of a spirit. much discussion has been paid in the ancient antiquity about eudaimonia, and we have in two very key philosophers that's addressing eudaimonia. First, Aristotle. According to Aristotle, eudaimonia is the highest human good, attainable through the practice of virtue, rationality, and purposeful living. Actually, Aristotle and the responded later on scholars already just understanding its approach as a so-called eudaimonic well-being, means an orientation toward personal growth, authenticity, excellence, and meaning. In the contrast, Epicurus, another Greek philosopher, trying a little bit in approaching eudaimonia more with a more hedonistic perspective, advocating a life that maximizing pleasure and minimizing pain and discomfort. This reflected the so-called hegemonic well-being, which just characterized by a pursuit of comfort, enjoyment, and avoidable suffering. Of course, that is the themes of eudaimonia. Many scholars, and even currently nowadays, discussing that potentially these opposing approaches is not exactly opposed or different in terms of the meaning, but we needed in a bit discussing a type of synthesis. That means it would be wonderful translated this synthesis as a concept that unified demonic and hedonistic elements. I think that potentially could be a framework nowadays, especially from the frontline physicians and in general primary care workers. It is important now to understand the concept of eudaimonia as translated in the current setting, having a frontline physicians among many crises, many times just suffering even from their professional life or all from many anxious and other depressive events. That means it is important a little bit when we discuss in eudaimonia and recommended eudaimonia as a theoretical setting to our colleagues, especially thinking that is a dynamic balance between meaning and pleasure. I think that's two key words, meaning and pleasure. And an important just having this integration, especially when our colleagues and ourselves struggling with emotional exhaustion and anxiety, and trying a little bit to recommend it resilience and joy in medical practice. Just as an epilogue to your question, I think that is important in thinking eudaimonia, especially when ourselves and our colleagues, healthcare professionals, family physicians, connect their personal growth and self-actualization to the relationship they building in daily life with their patients. And when thinking or linking this personal growth with the social impact of their work. At this time, medicine becomes not just a job, but a vocation. Means, in other words, an vocation that enhancing life and alleviating suffering. It is an easy job, certainly not an easy job, but I think that eudaimonia, as we translate it and integrate it in our professional life, potentially will be a guiding principle in reducing suffering and enhancing pleasure and joining with the meaning.
Thanks very much, Christos. Yeah, certainly that last point that you mentioned there about that the idea that, you know, obviously doctors can help their patients, but that through helping their patients, they can be basically replenished was a real, you know, yeah, it really resonated with me. Something clicked with me there, and I think, I really understood what it was you're trying to say. And I think a lot of people, without taking family doctors for granted, yes, this idea that it is a vocation is one that I've definitely seen, reflected back at us now, especially on World Family Doctor Day with family doctors embracing that idea. I must admit, when we first had this conversation, the word suffering came up a lot. Suffering, and I, from a communications point of view, trying to, do a happy campaign around the world, was always shying away from the word suffering. And I said, this isn't exactly, something that sells, to put it in a cross term. But through the conversation, I think I understood then the importance of turning towards suffering. Chris, maybe you could talk a little bit about that.
I will. If I may come back to that a bit later on, if that's all right, because I think it's really important. But I want to sort of first, I want to expand on what Christos is saying about sort of the nature of nature of us as human beings and what our sort of aims and aims. I mean, I love what Christos talking about, a combination of meaning and pleasure and about that sense of vocation. And so I promise you I'll come back to suffering, but I want to talk first of all about sort of what it means to be a person, and because I think we as doctors, I don't think we do it on purpose, but we tend to see, this is a bit of a, we tend to see patients as problems, and ourselves as problem solvers, and I think that can be quite limiting, both for our patients and for ourselves. And so I think if we have a richer view of what human beings are, including our patients, as people with agency, as people with creative capacity, as people who are capable of leading their lives, and ourselves, our job then is to help them, not to solve their problems, but to help them lead their lives a little bit more effectively. I think that gives us a stronger position in general, and certainly in the field of mental health and building mental resilience. I mean, not to show off too much, but I mean, this is the book that I wrote a while ago called Beyond Depression, where I was writing. I've got a whole chapter on this about sort of about the ideas of coherence and engagement, and I just want to talk a little bit about what I mean by both of those things. So by coherence, I'm talking about ourselves as being, we have an essential unity. We're real, we're valuable, and we've got the capacity to change and to make progress. We're not predetermined by our circumstances, by our biology or our social roles. We have the capacity to change. And I think I think there are several elements of our coherence. I start with one of my favorite philosophers, and don't go back as far as Christos, but the 17th century Dutch philosopher Spinoza, who's got a central concept of conatus, which I think translates best as desire, and so he writes about the desire by which each thing, including human beings, endeavors to preserve its being is nothing other than the actual essence of that thing. So I think we have a fundamental desire to exist and to persist in our existence. I think our memories are very important, that they can be turned into problems, but they can be turned into sources of energy. I think as human beings, we have an essential curiosity, finding out about new things, a sense of excitement. And I think we have an amazing imagination to produce new ideas about things that haven't already happened. And putting those together, I mean, I think Christos is going to talk about this a bit later on as well. I mean, our sense of coherence actually is strongly related to our health. A strong sense of coherence correlates with self-rated health. well, a weak sense of coherence predicts, there's actually research on this, predicts the onset of depressive disorder and separately the onset of diabetes. But our sense of coherence is not something we're stuck with. We can change it as a result of therapeutic interventions. And then the second bit, so there's a sense of coherence and also a sense of engagement. I think our sense of identity has important social dimensions. We make sense of ourselves in engaging with the world around us. And I think that's crucial in creating and sustaining our sense of identity and our well-being. And I mean, engagement, I mean, as family doctors, we're engaged in the practice of family medicine. And I think that's another wonderful philosopher called Alistair McIntyre from Canada has talked about the importance of coherent and socially established cooperative human activity, of which general practice is a very good example. Or engagement can take a simpler form of just the affirmation of ordinary life and the investment in our family, in our social spaces, in our intimate relations, and in our moral and spiritual orientation. Or engagement, it can also take the form of engaging with the circumstances in which we find ourselves, which might involve cultural alienation or might involve physical illness. And it's our determination with, if you remember the myth of Sisyphus and Camus, the French existential philosopher, his take on that, Sisyphus rolling his rock up the mountain. But it's our determination to make the best of that we can. And as Camus says, the struggle towards the height is enough to fill a man's heart, and we should imagine Sisyphus happy. And so what I'm saying very briefly is the combination of a sense of personal coherence and engagement with the world around us together enhance our sense of resilience, our capacity to maintain or regain well-being in the face of adversity. And again, but being very specific about mental health, people who adopt strategies to enhance personal resilience actually improve their outcomes in studies looking at depressive disorders in primary care settings. So that's my sort of take on developing what Christos is talking about sort of eudaimonia and sort of
but Chris,
with a more sort of current thing. Sorry, Dermot. Yes.
How do we bring this down into the clinic? And like, you know, it's good to have a conversation about Sisyphus and everything here, but yes. Like what would you like people to take away from this understanding of coherence and engagement? How can a family doctor put this into practice, dealing with a patient who has?
Well, I have lots of them, but if we just take Sisyphus and a Camus version on Sisyphus, I think we have a lot of patients, many patients whose life is a daily grind. They are, you know, whether it's a chronic mental disorder or chronic physical illness, they're having to get up every day and just work through it and just keep going and keep going. And so I think I'm going to come on to a bit about suffering and how we can help with that. But I think if we acknowledge that people are doing actually a fabulous job of keeping going in very adverse circumstances, and that they're rolling the rock, that they are keeping working at that. I think that is something that's important. And then the other bit about the sort of the involvement with the what Charles Taylor calls our webs of interlocution, just being aware of and encouraging people to take note of, their family, their friends, their religious beliefs, their social engagement, and all those things. Those are also intrinsically positive and therapeutic things to do. And then on top of that, sort of, if people have a sense that they are an intrinsically valuable person, Christos said, a sense of not just a sense of eudaimonia in the doctor, but a sense of eudaimonia in the patient as well. The patient, giving this person in front of me has intrinsic value and worth, and that getting that message across is also, I think, essentially a therapeutic activity.
Yes, and I think that Chris offering a fantastic ground, and also your question now how to translate when or talking with colleagues and especially when addressing a family physician, particularly in young physicians at the moment. Many times they asking that all of that we discussing is fantastic from a philosophical point of view, potentially theoretical, but not actually. That many of my students that they asking how to pursue, how to identify the meaning in my life. That is exactly a key question, and how we could just having or giving a purpose or significant in my experience when I'm meeting a patient. I think that is a key question. And already Chris, with a fantastic way, started discussing coherence, giving an excellent orientation to sense of coherence. I think that a sense of coherence is a concept that represents the individual's capacity to perceive life as structured, manageable, and meaningful. I think that everybody of us has a patience. We're thinking, okay, I am affected by many crises, but I think that we have many opportunities to resolve them, that expressing their own capacity quite positively. And we have on University of Crete, in the medical faculty, a couple of studies that indicate that people, they having a higher sense of coherence scores than having a very small or lower possibility in being depressive. I think that is a clear understanding. And of course, we have evidence from many settings that the question is how we could enhance sense of coherence in people and making them more strong, diminishing the probability in suffering and being affected by depressive symptoms, and also making more capable in reducing the job stress, because that's the family physicians as a front line always having in front of us job stress. I think that is one question. There are many interventions, either behavior or focusing on perceptual means and approaches, just giving us the opportunity and strongly suggesting that identifying opportunities in strengthening sense of coherence means the available intrinsic sources of our colleagues. The second that I'd like a little bit in stressing, and that is another work already carried out extensively at the University of Crete, is the cultivation of compassionate care. I think that is an important pathway, important mean in reducing stress and just giving the opportunity to enhancing capacity of the people, just enhancing also a pleasure together with meaning. I think that there are much evidence today across the world that provision of compassion is a protective factor against burnout, but also that is other mean to improve quality of care. That there are many scholars at the moment that they supported that compassion and compassionate care play a vital role in cultivating meaning of life. I think that also personally I tested it, especially in many personal and intrinsic crises. That means how we could utilizing compassion is still a difficult concept, is not entirely the same as empathy, is a more having a behavior component inside, and that means it is necessary to introduce many teaching methods to when asking our colleagues in addressing or providing compassionate care. And I think that I have copied one quote from any important a colleague, Megan Shen, which just saying the overlooked payoff to suffering is compassion. I think that is a key issue. To reduce compassion, it's just adapting. To reduce the suffering is important to adapt to compassion. I think that potentially compassion may be one of the most powerful tools we have to offer collective healing and personal growth. I think that's we provided with Chris a couple of pathways, if we can say, practical opportunities through intervention in enhancing our work capacity, in diminishing the probability in being depressive, and also reducing the daily stress and the job stress.
Yeah, very good. Yeah, I can say a bit more about your previous question, Dermot, about suffering. I think that fits very well with what Christos is just saying. Is that okay?
Yeah, of course. Yeah, I mean, yeah, it's you know, as a non-medically trained person, the idea, I think, to me, that compassion can be based in science and that has proven medical things was new to me. But yeah, if you could speak more about that.
But I'm going back in time a couple of thousand years. So I mean, I think this is about suffering and about hope, and I think we've been talking about the things that are good for us, but I think in terms of I think we have to talk about obligations as well. I think as family doctors we do have moral obligations, but there are also clinical obligations, and I think it's the acknowledgement of suffering and the offer of hope. And I think what Christos is talking about in compassion is doing both of those things at the same time. And I think our duty to relieve suffering, it goes back as far as you can think. And I think we often find it difficult to be open in the face of suffering. We tend to shy away because it's just too hard for us. But actually that closes off our compassion and it stops us from being healers. So I think we should have the courage to turn towards suffering, to recognize it, become curious about patients' experience, and become more present and engaged. I think that bearing witness to suffering, giving our patients a sense of being understood and accepted, is the first essential step towards hope. So this is where I'm going back 2,000 years to. I'm not going back as far as classical Greece, but to Rome and to Virgil. I'm sure some of you will have come across Virgil's epic poem, the Aeneid. And in the first book, we find Aeneas, who's the central character. He's a refugee, actually. He's been driven away from his home in Troy, and he's in Carthage. He hasn't yet fallen in love with Dido, but that's going to happen later on. And he's looking at a mural in a temple which depicts the battles of the Trojan War and the deaths of many of his friends and countrymen. And he's overcome with emotion, and he offers a rousing tribute to his fallen comrades. And within that, there are just three words, which I think are absolutely brilliant. And this is Latin, I'll translate it. It's sunt lacrimae rerum. Sunt lacrimae rerum. And I think that brings us to the heart of the link between suffering and hope. So just to translate that a bit, rerum, it's the genitive term of res, things, and it can be understood in both objective and subjective terms. So it can be translated, so this phrase, sunt lacrimae rerum, that can be translated as either there are tears for things or there are tears of things. And so the first version indicates the burdens that we or our patients have to bear, the frailty of human existence that so many people experience. But the second version is interesting because it indicates that things feel sorrow for our suffering, that in some sense the universe feels our pain. But of course it isn't one or the other, it's both. And I think Virgil's fully aware of the ambiguity, and you will want us to understand both meanings at the same time. And so does one of my favorite, not a philosopher, but a poet, the Irish poet Seamus Heaney, who translates that phrase as there are tears at the heart of things. And for me, we can translate this directly into the consultation. And it's such a rich and powerful concept, because at the moment, when I experience and express compassion for the suffering of the person in the room with me, both senses of sunt lacrimae rerum are in play. My patient can express distress and pain and suffering, knowing that in me they're finding understanding, compassion and safety. And my consulting room has become, even just for a few seconds, a few moments, it's become a sanctuary. Again, this isn't just sort of airy-fairy stuff. This is real. Our commitment to hope is a fundamental element of overcoming any illness. Hope is a therapeutic tool, and it's one of the most powerful aspects of the doctor-patient relationship, which we all too often ignore or downplay or don't really believe in. But it's so important, especially if it's based on a genuine understanding of our patients' concerns and expectations, and then linked with good evidence-based practice. So I mean that's what I want to say, that this acknowledging suffering, compassion, hope, that's all together in potentially in every consultation, and it's absolutely central to what family doctors. It's what we do every day. I don't think we recognize most of the time. We don't give ourselves enough credit for what we do, but I think that's absolutely central to building mental resilience, central to what we're talking about on World Family Doctor Day.
Thank you, Chris. I think you put that really, really well. I'm just looking at the chat, and there's some questions coming in. One on how to reach patients who haven't taken the step of seeing a doctor, and related, I think, to that as well, because of issues around stigma as well, is how do medical culture and ethnic culture influence perception on resilience and meaning? So often in the medicalized way of viewing mental health, people sometimes are still wary or the stigma surrounding that. But I feel like we're talking beyond medicine here. We're talking, about humanity and human connection here.
Yeah.
So I suppose, how can we use these ideas to reach those people who don't want to medicalize their thinking?
Christos, do you want to start on that one?
Yes, I start. Thank you very much. I've seen so many important face of my colleagues, and now one of them is Sandra. Hello, Sandra Fortes from Brazil, because your question is just addressing local culture, and certainly, and we have some evidence from the island of Crete when we studying sense of coherence with spirituality and religiosity, because always spiritual in generally concept, and even religious as a part of spirituality, we find a parallelogramic linear regression of them, that there are many people they saying that I maximize my pleasure and everything around of me is predictable and manageable because my spiritual and cultural beliefs. That is very, very important in respecting local culture, potentially have an enormous impact on developing a sense of coherence. And I think that is an important question, and certainly that's giving a value to the notion of culture, and also is another area of family physicians which start coming across and giving opportunity to not only study the local beliefs system and to what extent that has an impact on the coherence or the understanding of the purpose and the meaning of their life, and also adapting and providing and designing their vision to change or improve the current situation. Thank you.
Yeah. I mean, I think that's really important. Yeah, it's an understanding of and respect for sort of for different cultural perspectives. But I mean, I think also both Christos and I have been talking a lot about the word suffering, and I think in this context that might actually be quite helpful, because I mean that's not a medical term. No, we're not making a diagnosis of suffering. We're not putting somebody in a category. We're just we're listening and we're acknowledging. And I think, you know, if we can be a little bit more relaxed about what we do in a consultation, and we don't have to write down a diagnosis. We don't have to write down a formal sort of management plan. We can just listen to what our patients are telling us, and ask them to, you know, to explore, and to, as I said, to deliberately turn towards the suffering and be curious about it and find out from them. That is respectful of whatever culture they may be coming from and whatever way they're expressing that. But what we're both saying is that the fact of doing that is intrinsically a therapeutic activity. So I think, you know, you're not just listening. You're actually, the listening is giving hope. It's actually making a difference to that person, regardless of their formal diagnostic status, regardless of their culture.
Thank you very much, Chris. I'm very enjoying also your approaches on suffering, which as always, that's connecting with the hope. Of course, you dedicated much of your efforts in analyzing suffering. Another from a U.S. Colleague, Ronald Epstein, has also addressed it very much, and also in his books. And I think that's my proposal, especially to our colleagues and to our community, a little bit thinking suffering before the symptoms. When we discuss in the so-called the natural course of disease, and needed to go to the stems, to the root of any nosological anti, I think it is very important starting from suffering, because suffering potentially just start the so-called inflammation procedure. I think that is very important for family physicians, or having a better understanding what it means suffering, especially when they're addressing their patients, and asking not only how many disease you have or what type of disease or symptom you have, but simply asking, are you suffering? I think that is a key question, and potentially also addressing ourselves and enhancing also self-compassion. Yes, this is very important. Thank you for addressing this concept.
I've just put in the link, Ron Epstein's book. It's called Attending.
Attending. Excellent. We have in common sources of reading, Chris. Thank you.
It's a wonderful book. Yeah.
Yes.
Yeah.
Thanks very much. At this stage, we're probably going to draw to a close. We have at 45 minutes we're going to end it. So I invite anybody who has questions to raise their hand, and then I can call on you to ask a question. I have also a question as well, because this just today, as I was running the campaign and posting stuff on social media, we found a comment said somebody took issue with the idea of building resilience, and their problem was that they were it seemed like the responsibility of handling stress and overwork falls on family doctors, and it kind of absolves power or governments or power structures from kind of coming in and taking the kind of responsibility, and that resilience in this sense basically means, in a political sense, means that help isn't coming, just deal with it. You know, this is like I suppose what we meant by this and what by resilience is more on the personal level, and in the interpersonal level, maybe you can talk about that a little bit, and then we'll go to Sandra.
Yeah, that's a really good point. And I mean, there's always that tension between what can or should you expect the family doctor to do, or the individual who is suffering to do, and what should you expect the state, government or whatever. And I think, I mean, the answer is it's not one or the other, it's both. But some people will be in very, very difficult situations where there ain't much help coming, and they have to build on things themselves. But I think, the point I want to make is that yes, of course, governments and states and health authorities should be doing whatever they can, and we should be having the right medication and the right therapies and all those things. But on top of that, the family doctor's interaction with patients, and patients themselves can also do things to improve, to reduce suffering and expand their resources. So it's not either or. It's both.
Thanks, Chris. Christos, you want to say
I think
something?
that responding to your key questions, and now since we're reaching at the end with Chris, we have prepared, of course, some personal approaches how to enhance mental resilience, simple guidance, especially from the young colleagues. I'm seeing now a couple of suggestions from them. I think that the first, that's almost 4 recommendations. The first, identify a clear sense of purpose and meaning in life and practice. Life in practice, that's together, that's there's a synergy. A second, find genuine pleasure in alleviating suffering and providing compassion and care. Already we discussed. The third recommendation is cultivate self-compassion. Recognize that failure and imperfection are intrinsic to the human experience. And the fourth, maintain the balance. Balance was also a key word in ancient antiquity in personal and professional life by integrate eudaimonic and hedonistic well-being dimension. I think that's summarizing a couple of statements, especially in this important day for ourselves as family physicians.
Thanks, Chris. We'll go to Sandra now. If you have a question, Sandra.
I have a question. Hi, Chris and Christos. It's good to see you. And again, and I would like to include, because culture was mentioned, the cultural aspects. I want to include another concept and that we are studying here in Brazil that comes from indigenous populations from South America, which is called originally from Peru and from Ecuador and Bolivia, which was called sumac causai in Quechua, and it's translated as bem viver. We still have problems with the translation to English because it's good living or living good. We are still discussing that in a paper, but the point is that they don't consider the aspect of mental health. They consider that good living is when you consider your collective group. So it's a collective conception of being well, not an individual. And also a natural, environmental concept. So the second component was an environmental concept. So if the environmental is not good, and it always reminds me of family doctors, that are discussing this. And also the third one is considering transcendental aspects. So this new concept, we started working with them in Brazil now, because mental health does not apply to indigenous populations. They don't understand. And in a certain way, we are considering they are much more advanced than us when it comes to a collective concept that can change things if we still have time.
Well, I guess that comes back to the idea of engagement, that, the importance of engagement through this, understanding themselves through their connections with other people and that collective view of health. Yeah, certainly. I think, there's lots to learn, back and forth. Okay. We are approaching the 45-minute mark, unless anybody has any questions. I know Professor Christos has an engagement right afterwards, so we can't go on any longer, but I just want to thank everybody for joining us here today. We will make the recording available, and I'll try and email it out to everybody who's registered. And don't forget to take a moment for yourself today to appreciate the work that you guys do in your communities and in the world. And happy World Family Doctor Day to everyone. And yeah, have a nice evening, morning, wherever you are.
Thank you.
Okay, bye now.
Bye bye.
Thank you, Diarmuid.
Bye. Thank you very much. Bye.